Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. The topic of the today's lecture is deep tendon reflexes. There have been a lot of reflexes that are used in the assessment of the different elements of the nervous system which are responsible for the functionality of the particular structures. This has been used for the past more than a century in order to assess the status of the different elements of the nervous system. That means there have been several reflexes used to assess the status of the different elements of the nervous system, which contributes to its functionality. They have been used in the neurological examination over a century because of their safety, no cost involved, can be performed rapidly with good predictive value and require no costly equipment. Well, today in our lesson, we focus on the deep tendon reflexes, which are named appropriately by the term muscle stretch reflexes. This is the term used for deep tendon reflexes. Well, grading is based on the clinician's subjective assessment of amplitude, which has a wide range of that can be normal. So, amplitude has got the wide range of normal values that can be normal. Well, if they are asymmetrical, associated with the other features of involvement of the nervous system, they carry some pathological significance. But isolated hypo or hyper response without other findings generally not considered as pathological. That means if deep tendon reflexes are asymmetrical, okay, associated or without the features of the other parts of the nervous system, they have got pathological significance. But isolated hypo or hyper reflexes, okay, without the involvement of the other structures of the nervous system, they carry no pathological significance. Well, there are 6 muscle stretch reflexes that have been in practice and they have been used in the clinical examination of the nervous system regularly. They are biceps, brachioradialis, also called supinator jerk, triceps, knee, ankle, and jaw jerk. Coming to the anatomy and physiology of these reflexes. In all the 5, that is the biceps, triceps, brachioradialis, knee and ankle jerks, that is except jaw jerk, the stretch receptors which are found in the muscle spindle are stimulated when you tap a particular area. Okay. With this, there is minimal stretch on the muscle. There is minimal lengthening of the muscle tissue. That causes stimulation of the stretch receptors that are located in the muscle spindle. Okay. Efferent impulses, they are carried by the 1 alpha neurons whose cell bodies are located in the posterior nerve root ganglion. Okay. From here, they directly synapse to the anterior horn cells. Okay. Activated anterior horn cells they send the efferents along the alpha motor neurons, to cause the contraction of the muscle. Okay, this is how it is. Stimulated muscle spindle activate the stretch receptors, and the 1 alpha neuron carry the afferent signals to these cell bodies in the posterior horn cell, posterior root ganglion, which directly stimulate the anterior horn cell, and the efferent alpha motor neurons carries these signals leading to contraction of the muscle. Okay, this is the reflex arc that is completed. Afferent traveling from the receptors of the muscle spindle to the posterior root ganglion, which directly stimulate the anterior horn cell. From there, efferents take to the muscle, leading to its contraction. Okay. When the muscle spindle reflex is initiated, the afferent signals branch off from the alpha neuron and inhibit the interneurons. Okay, prevent the contraction of the opposite group of muscles. Okay? For example, take the knee jerk. The afferents from the muscle stretch receptors are carried to the spinal cord and directly stimulate the cell bodies of the alpha motor neuron, efferents, resulting in the contraction of the corticeps. Okay? The branches of the afferent neuron carry inhibitory signals synapse with the cell bodies of the interneurons that innervate the flexors of the thigh. Okay? That means during the knee jerk, corticeps muscle is activated and the hamstrings are inhibited. So there is a contraction of the corticeps and relaxation of the hamstrings, which are flexors. Okay? And the descending corticospinal fibers have modulatory, generally dampening effect on the monosynaptic reflex arc. Okay? The corticospinal fibers, they have got the inhibitory influence on the anterior horn cells that stimulate the contraction of the muscle in this particular monosynaptic reflex arc. So, this reflex arc has got musculoskeletal component, okay, peripheral nervous system, and the central nervous system. So, the disturbance in any one of these results in the abnormal response. There could be pathological lesions which are numerous, affecting the upper motor neuron, which extends from the cortex down to the anterior horn cells. Lower motor neuron, which involves the spinal segment and the peripheral nerve, that to the junction of neuromotor junction. Okay. So the reflex arc is having musculoskeletal component along with the peripheral nervous system and the central nervous system as the components. Disturbance in any one of these results in the abnormal response. This is about the deep tendon reflexes, that is 5 DTRs, that is biceps, triceps, brachioradialis, knee jerk, and the ankle jerk. Because they have got the afferents running in the peripheral spinal nerve, and they have got the center in the particular segment of the spinal cord, and they have got the efferents supplying the particular muscle. This is the monosynaptic reflex arc. And they have got the corticospinal fibers as the having the modulating influence on this particular reflex arc, especially dampening effect on the anterior horn cells, so much so this monosynaptic reflex arc. Coming to the jaw jerk, the afferents start from the proprioceptive signals, which are carried in the mandibular division of the trigeminal nerve to its mesencephalic nucleus in the pons, okay, which in turn sends the signals to stimulate the cell bodies in the motor nucleus of the trigeminal nerve, and the efferents supply the masseter muscle on both sides. Okay. The modulating upper motor neuron comes from corticobulbar fibers, unlike corticospinal fibers in the spinal reflex arc. Coming to the 6 muscle stretch reflexes, we try to understand in the format as follows. We give the name of the reflex, we talk about the center of the reflex arc, that is in the spinal segment, that is root value for this particular reflex, and the peripheral nerve that is involved in the reflex arc, and the location where it is stimulated or struck. For example, biceps. Root value or the center for the reflex arc is cervical 5 and cervical 6 segments. Peripheral nerve that is involved is the musculocutaneous nerve. Location where the stimulus is made is at the anterior area anterior to the elbow, that is over the biceps tendon. For triceps reflex, the center is C7 and C8. Peripheral nerve is radial nerve, and the area where it is stimulated is posterior to the elbow. For brachioradialis, segmental innervation is C5 to C6. Peripheral nerve is radial nerve, and location where it is struck is on the radial side, 10 centimeters above the radial side of the wrist. For knee jerk, it is L3, L4. The peripheral nerve is femoral nerve. You stimulate on the patellar tendon just below the patellar prominence. For ankle jerk, lumbar 1 segment is the center for the reflex arc, and the peripheral nerve that carries the impulses is the tibial nerve, and the stimulus that is made is on the tendon of tender Achilles of calf muscle. For jaw jerk, the center is pons, and the peripheral nerve is the mandibular division of the trigeminal, and where you struck is on the mental protuberance over the chin. This is how the name of the reflexes and the center for the reflex arc and the peripheral nerve that is involved and the location where you strike the area to elicit the reflex. There have been a rhyme that has been used as a mnemonic for the students to understand the root value of these particular reflexes. Try to remember this rhyme. 1, 2, buckle my shoe. S1, S2 root value for the ankle jerk, that is tibial nerve. 3, 4, kick this door, that is stands for lumbar 3 and 4. The root value for knee jerk, the peripheral nerve is femoral nerve. 5, 6, pick up stick, that is C5 and C6, explaining the root value for the biceps and brachioradialis, that is radial nerve. 7, 8, lay them straight, that is C7 and C8, root value for triceps. That means when you are Want to buckle my shoe. When you are trying to buckle your shoe, you are bending down to reach the ankle. That is sacral 1 and 2. 3, 4, kick the door. That means you are trying to kick around the knee with the knee extension. That is the segment used is the lumbar 3 and 4 for knee jerk because you are trying to kick with the extension of the knee. The root value for this is L3 and L4. That is why 3, 4 kick the door. Then 5, 6 pick up stick. That means to pick up the stick, you are using the biceps and the brachioradialis, their root value being 5, 6. 7, 8 lay down straight. When you want to lay down straight, you are supposed to extend the arm at the elbow. It is the action of the triceps. So root value for this is the C7 and C8. This is how the rhyme can be used as a mnemonic to remember the root value of these reflexes. This is for the students to remember this segmental innervation of the various deep tendon reflexes. Well, what is the equipment you use? It can be specialized or improvised. In specialized group, you use the knee hammer, that is the reflex hammer, which could be head of which could be triangle or T-shaped or circular. Whereas in improvised technique equipment, the clinician's finger can be used to tap the tendon, or you can use the rim of the telescope as well as the rim of the smartphone. And how do you prepare the patient? For all the 5 reflexes, the patient should be kept well relaxed. Muscles above and muscles below the joint should be well relaxed. Joint should be positioned in 90 degrees, loosely hanging with support if required. Strike on the joint with hitting the surface of the hammer 90 degrees to the long axis of the tendon. So, strike using adequate force to elicit the response. Clinician should observe the contraction of the testing muscle. The biceps for biceps reflex, quadriceps for knee jerk. Observe the contraction of the testing muscle. Okay. For jaw jerk, ask the patient to keep relaxed, drop his jaw with opening his mouth, wash your hand, keep the ventral surface of your left hand, fingers, and the mental protuberance of the shin of the patient. Strike on the dorsal surface of your fingers and look for the response. The technique. Technique is variable with the type of the equipment you use. Okay. If you use the round head knee hammer, swing the head of the knee hammer, let it fall with gravity. That force is used to strike the area to elicit the reflex. Well, when this is especially used for knee jerk. When you are trying to use the same for the biceps, you use as if you are swinging the drumstick. That is the force you use for the biceps. Okay. Then when you are using the stethoscope, rim of the stethoscope, you hold the stethoscope few centimeters away from the diaphragm, then swing it so that it will hit the area where it has to be stimulated. The clinician's fingers are used in a situation where there is hyper-responsiveness. In the same way, the rim of the stethoscope also used in a situations where there is hyper response. Okay, this is how you use the different techniques to elicit the response. And after looking at the response, you have to grade the reflexes. Grading depends upon the amplitude of the movement of the appendage or the limb distal to the joint. This is the grading system that is used by the National Institute of Neurological Disorders and Stroke, that is NINDS. According to this scale, grade 0 there is no movement, grade 1 shows less response, rather trace of response, which is less than normal amplitude. In grade 2, reflex is on the lower half of the normal range. Okay. In grade 3, reflex is in upper half of the normal range. Grade 4, reflex is enhanced more than normal range with clonus. Okay. In grade 5 is also described wherein reflex is enhanced with sustained clonus. This is how the grading of the DTR is made in order to understand the response to the stimulus. Then coming to the clinical significance. The lesions can involve in any part of the pathway of the reflex arc. It could be peripheral neuropathy or diabetic neuropathy. And there are numerous causes to explain the pathological lesions. It could be in the lower motor neuron, or traumatic or ischemic. The lesion could be in the upper motor neuron. Well, it could be mixed in spinal injuries. Because of the extensive network of the reflex arc of these deep tendon reflexes, there will be numerous pathological lesions which may influence the response of the deep tendon reflexes. In the lower motor neuron, if it is traumatic, it will show the hyporeflexia and hypotonia with loss of power and severe wasting, disproportionate to the degree of disuse. In upper motor neuron lesions, there could be hypertonia with hyperreflexia and weakness. And the wasting is proportional to the degree of misuse. There could be mixed spinal injuries. Mixed response occurs in spinal injuries, especially if there is an injury around the spinal segment involving the, like say cervical 4. There could be hypotonia of the biceps with hyporeflexia. Okay. The same injury causes hypertonicity of the quadriceps muscles with hyperreflexia. Okay, because the lesion is above the L4-5 segment, which is for the knee jerk. So this is a knee jerk. For the knee jerk, it is upper motor neuron lesion. For the biceps reflex, it is lower motor neuron lesion. So it will be mixed presentation with the same injury to the spinal cord. So this is all about the theoretical aspect of the deep tendon reflexes or muscle stretch reflexes. Then we go to see some of the pictures explaining this particular reflexes. In this particular picture, see there is a round-headed hammer is used to strike the patellar tendon, which will cause the stretching of the quadriceps muscle, stimulate the stretch receptors in the muscle spindle, and the afferent alpha neuron takes these impulses to the posterior root ganglia. From there, it directly synapses with the anterior horn cell. Okay, from there the efferent pathway takes the impulses to the muscle, resulting in its contraction of the quadriceps. As I told you, there are also impulses taken from the inhibitory interneurons to the hamstring muscles, which are the flexors of the knee joint. Okay, so hamstrings are inhibited and the quadriceps are stimulated in order to cause the response to knee jerk in the form of extension at the knee. The amplitude of which will be assessed in order to explain the grading of the reflex. This picture also shows the same pathway, that is the afferents going to the posterior root ganglion, efferents running in the motor neurons to cause the contraction of the muscle. This picture also shows the same pathway. Here, the clinician is eliciting the knee jerk on the patient. These are the hammers used to elicit the muscle stretch reflexes. Here is the round-headed knee hammer used to elicit biceps at C5, brachioradialis at C5 and 6, and the triceps jerk stimulating the C7, and knee jerk stimulating the receptors that carry the afferents to L4 segment of the spinal cord. Here is the ankle jerk, which stimulates the S1 segment of the spinal cord. This picture shows how the knee jerk is elicited with support, and the stimulus is made onto the patellar tendon. The ankle jerk, when the tendon is stimulated, and the clinician is supporting the foot of the patient, creating a bit stretch on the tendon Achilles. Well, this slide shows the different reflexes and the grading of the response. Okay, biceps reflex segmental innervation is C5 and C6, brachioradialis is C6, triceps reflex is C7, knee jerk or patellar reflex is L4, and the ankle jerk is S1. Okay. The grading as described earlier, in this particular picture it shows 0 is absent response, 1 plus is the hypoactive reflex, 2 plus is normal, 3 plus is hyperactive, okay, 4 plus hyperactive with clonus, and 5 plus is hyperactive with sustained clonus. So the grading of the reflexes can be remembered with the information given in this particular slide. Here is the clinician demonstrating biceps jerk. So he is keeping the thumb of his left hand onto the biceps tendon at the cubital fossa and hammering on his finger in order to cause the stretch reflex of biceps jerk. This is again the picture showing the knee jerk. So where the patellar tendon is stimulated, valley of impulses are carried by the afferent to the spinal cord. From the spinal cord, efferents come to the muscle of the quadriceps, causing contraction of the quadriceps and relaxation of the hamstrings, resulting in knee jerk. That is extension of the knee. This is round-headed knee hammer that is commonly used to elicit the muscle stretch reflexes. Well, thank you very much for patient listening. Hope you like that my video related to the muscle stretch reflexes and the pathophysiology involved in that and the mechanism of eliciting the reflexes carefully and observe for the degree of response depending upon the amplitude of the movement of the distal limb and try to arrive at the diagnosis whether the lesion involves the upper motor neuron or the lower motor neuron. Okay, and try to remember the rhyme that is used as a mnemonic to understand the root value of all these deep tendon reflexes except jaw jerk. Okay, jaw jerk, try to remember it is because of the efferents they come from the motor nucleus of the trigeminal nerve of both sides. Okay, and innervate the masseter muscles bilaterally. Okay, it is the bilateral response that is seen in the jaw jerk due to the supranuclear lesions. That is especially in the pseudobulbar palsy. You see this jaw jerk most commonly in the children with spastic quadriplegia, wherein there is supranuclear fibers are damaged, innervating the motor nuclei of the cranial nerves, including the that is corticobulbar fibers innervating the motor nuclei of the trigeminal nerve. So it is the bilateral lesion that results in pseudobulbar palsy, resulting in positive jaw jerk. Hope my dear students, you like my video. Please subscribe to my video and we'll meet you in the next class. Until that time, bye bye and thank you once again.